Go ahead. Thank you. What I was going to do first was just give a quick overview about the lectureship. And this lectureship is in the name of Dr. John F. Caffey, who is really the first pediatric radiologist that ever existed and really started our field. And I wanted to just give a few slides about him. I recently fell into a large amount of his memoirs, and part of that was because Lionel Young, who was radiologist in chief here in 1976 to 1986, recently passed away. And this is just a picture of him in our department with the iconic Fred Rogers, who came to visit the emergency room here at the Pittsburgh Children's in the 70s. And he was just showing him how to do an x-ray. But his daughter, who actually just was appointed chair of radiology at Boston Children's, Tina Passant, was going through some of his belongings and found 2 boxes of John Caffey's works and the papers he read, the papers he wrote. And so over the last year or so, I've been starting to go through some of that work and finally is starting to learn who this person really was. And he was born in 1895, trained in Michigan, and I'll go through this fast because we obviously want to get to our lecture, and did his medical training in St. Louis, and also was involved in World War I. He eventually was in a private practice pediatrician initially, and then eventually landed at Columbia, and was very involved in infectious disease, and was one of the first to actually describe some of the osseous lesions of syphilis. And one of the things that I found in his memoirs was this comment that at the time, there was no pediatric radiology. And if there was any imaging, the conference was given by the pathologist. And he just thought it just wasn't enough. And he was very outspoken. And so in 1929, they built a new pediatric hospital at Columbia, and the chair of pediatrics at the time hired him as the first pediatric radiologist. And that's where he really started the field. And this is him in the early 1930s. And then this is him where he finished his last decade of his career here at Pittsburgh Children's in 1963 till he passed away. His seminal work really was this paper, which was the first to describe non-accidental trauma and the imaging findings and what that meant. But what I wanted to show you was, as I've gone through his memoirs, I did find this, which you guys may know more about this lectureship, but he was awarded this John Howland Medal from the American Pediatric Society, which is one of the biggest honors. I don't know if it still exists, but it's definitely a big one. And I was looking at all the pediatricians who, the neurologist, Bronson Crothers, cardiologist, Helen Taussig, and there's John F. Caffey, who got this award. And if you look at his lectureship that he gave a talk about the importance of imaging in child abuse and really put it out there that we should have pediatricians who specialize in child abuse. And arguably, this lecture set the field for child advocacy. So a radiologist driving the clinical side. So he did work here at Pittsburgh Children's till 83 years of age, and worked to the morning of his mission, where he and then passed away at Presbyterian at the time. No, Children's was next to Presbyterian. So this lectureship means a lot to me, to our field, just John Caffey. I've had many really esteemed speakers come over the last couple of years, and even have had a pediatric cardiologist give this lecture. PhD researchers, but this is the first time that one of my trainees is coming to give a lecture. So I'm really, really proud of Minsun. She did her training at Stanford, her undergrad training, and her medical training at Vanderbilt, did her residency here at UPMC, and this is where I got to spend time with her. And she did 6 months of pediatric neuro imaging with me in her 4th year and did some research. And since then has really spent most of her time now at CHOP and is one of the few pediatric radiologists with 2 R01s. This is a huge accomplishment for the clinician scientists in our field. And her work has really been focused on developing contrast ultrasound agents, both in the preclinical, but also in the clinical realm. And particularly in using it in trying to understand brain health disease and acute brain injury, hydrocephalus, neonatal brain injury, and understanding vascularity in the brain. So I'm very proud to introduce her to give this lectureship. Thank you.
Thank you so much, Dr. Panigrahi and the entire team for inviting me for this lecture. So I am a pediatric radiologist at Children's Hospital of Philadelphia and happy to be here. As Dr. Panigrahi said, I am a graduate from here, so I have this disclosure. So 2015 was my graduation year, and I have to say UPMC really prepared me well for my academic career in pediatric radiology, and I'm very thankful and so happy that I'm back here giving a lecture. So privileged. So today I'll be talking about brain ultrasound. As you know, if you look at this tiny baby, we cannot argue that brain ultrasound is a very valuable tool. And it's non-invasive, portable, non-sedating, non-ionizing, but I think we all agree also that there are limitations to brain ultrasound. There's MRI, there's CT, why use brain ultrasound? So this lecture is pretty much dedicated to showing you the power of brain ultrasound and kind of the future directions of this technology. Specifically, there are many advancements in anatomic detail and functional insights, how this technology can improve those too. So if you look at color Doppler, this is oftentimes used in some institutions to capture some of the functional information in the brain. We don't use it, but there are many institutions that use it. But some of the limitations include that it is limited to assessing macro vessels, large vessels, and it has therefore limited functional information. There's definitely advantage to this, but limitations as well. But nowadays, there have been tremendous advancements in anatomic and functional ultrasound. So in the top left, what you're seeing is a coronal plane through the brain in an infant with microvascular imaging. It's actually an advanced Doppler technique, which allows you to see small vessels in the brain. And on the bottom is just grayscale anatomic image of the posterior fossa, the cerebellum in view. And on the right is actually a sagittal view of an infant brain, and you can see vessels pulsating. And that's tremendous because this kind of image has not been seen before. And so we don't have a clue about how these vessels pulsate real time. And it's pretty incredible. Now, this technology called microvascular imaging, it gives you a detailed view of cerebral microvessels, as I told you, to the level of cortical vessels and their branches, superficial medullary, deep medullary vessels, and ependymal vessels. In this infant, by the way, is not a normal infant. There's engorgement of a lot of these vessels, which is abnormal, but I'll review that in a little bit. Then take a look at the extra-axial space, then and now. It's been about, that image was taken about 5 to 10 years ago by one of our radiologists, old-time radiologists, who's really set the fundamentals of neurosonography in our department. But as you can see, it's very blurry. It's not high resolution. By the way, there's a thrombus in the sagittal sinus. You can see that. On the right is now what we can see with microvascular imaging of the near field. And you can see all these squiggly, extraaxial vessels, leptomeningeal vessels, superficial cortical vessels. In an infant, by the way, has lymphatic disorder. So pretty incredible functional insights here. Let's go through one case and see how this can improve our diagnosis and just clinical management in general. Then later in the lecture, I'll talk about more advanced research applications. So this is an infant who has a suspicion for injury, and this is a coronal view of the brain with frontal horns in view. Just take a moment to look at if you can see the abnormality. You can shout out if you want to. I apologize, there's some allergic to cold weather, but take a look at the asymmetry. So a lot of radiology is about asymmetry. And you can see that on the left side, there's engorgement of the deep medullary vessels, which is the veins, and as well as extraaxial vessels here, superficial as well as deep medullary. Let's take a look at sequential images. Here, you can see engorged vessels there on the left frontal lobe, more posteriorly, and also the extraaxial vessels, very busy right there. So this was a case of left frontal infarct. I'm not sure if you noticed, we're able to tell on grayscale, but this is the kind of functional insights that you can obtain in an abnormal case like this, where you may not be able to tell on grayscale what the injury is. Now take a look at this coronal slice of the brain. It's a pretty abnormal, too echogenic, but you'll be surprised when I show you the next slide. This is too much, too much. That's normal. Lenticular striate vessels. So when you see that, you're shocked, okay? And you kind of wonder, is this due to motion degradation? Because, this technology is pretty sensitive to motion, so you go a little bit posterior. You can clearly see that these are vessels and not a smudged artifact. This infant had a profound hypoxic ischemic injury in the setting of placental abruption. It's a preterm infant. And unfortunately, with that type of flow in the basal ganglia, the infant passed away shortly after the exam. It's unfortunate, but this gives you a clue to the power of these functional sequences that we can get. Now, this is as you know, preterm brain injury. You're all aware that this is due to predominantly venous pathology, where you can have venous hemorrhagic infarcts. And in the distribution of veins, where it looks like a chandelier or a fan. On the top are brain ultrasound images, in the middle, CT images, and at the bottom are MRI images. You are familiar with this image where you have echogenic, blood products. There's a little bit of germinal matrix bilaterally, but on the right side, there's parenchymal involvement, which is grade 4. What is perhaps surprising to trainees as well as radiologists is this picture where we're not used to seeing this. We are used to seeing echogenic hemorrhage in grade 4, but we're not used to seeing engorged veins that precede the hemorrhage and venous rupture and hemorrhage in this entity. So there's a lot to learn about this, just diseases in general, but this gives you a functional insight into the temporal progression as well as etiology of these diseases. And there's a lot of potential as an imaging biomarker guiding therapy and also monitoring therapy with these tools. When you talk about periventricular white matter injury, I think all of the trainees in radiology would agree this is probably very, very, very diagnostically difficult. It's very subjective. For us, it's more like if you see coarsened, heterogeneous, increased echo texture, yes, there may be periventricular white matter injury, but it's been a challenge. But if you can see the asymmetry here in the periventricular venous engorgement, can't tell you all of these are veins because this is not sensitive to arteries or veins yet, the ones in commercial systems. But you can see that the right frontal white matter has injuries as evidenced on hyperintensities, on MRI, coronal slices, and you can see the engorgement that is correlating to this these MRI images. Now, when you talk about infection, of course, it's kind of occult. It's a clinical diagnosis. We only get to see it when it's complicated, when there's abscess, when there's gross ependymitis or ventricular, products. And this tells you, so the infant comes in with a quasi-normal brain on the top, and 23 days later becomes like this. If you do microvascular imaging of the, this is a sagittal coned-in image of the deep gray matter nuclei, and you can see that the vessels are very irregular in the meningitis case. And on the right is a more normal case, not infected. So very interesting. It has diagnostic potential. It's in the preliminary phases of being applied at our institution. We have integrated as part of a brain ultrasound protocol. So we do it for every brain scan. But we know some of the utilities of it, but we also know that there's a lot to learn from these technologies. Now, if you look at neonatal ECMO, I would say this is a very, very challenge for us. And in terms of diagnostics and management, there's a tremendous gap in care in terms of neuromonitoring, and they have poor neurologic outcomes. If you look at these babies, connected to multiple support devices, of course, brain ultrasound is a critical tool. There's a lot to learn, though. We've done some retrospective studies, not yet prospective. Prospective is going to be conducted under a seed grant, but the images on the right and left in the red, outlined, those are the ones that had poor outcomes, and those that were imaged during ECMO. In the middle is sort of what you typically see during ECMO, although I can't generalize. They do have slightly reduced perfusion, but it was interesting to see that some of the infants had fluoride increased flow. For whatever reason, it could be autoregulation, it could be due to evolving injury, but these infants tended to do poorly. However, we've also seen that it's not the norm. It cannot be generalized, because we've certainly seen infants that had reduced flow and also had poor outcomes. So we're trying to get to the bottom of whether it could be a useful prognostic tool, and we're in the process of doing a prospective investigation. Well, this is kind of, interesting. Wanted to share that. This is a sagittal view of the brain in a post-hemorrhagic hydrocephalus infant. And that pulsating structure in the middle, I'm not sure if my, this one is CSF. It's shooting this way to the third ventricle. I'll play again. Probably because there are blood products in the ventricles that you're able to see the signal in the ventricles, and you can really see the CSF flow. Not sure if we can, definitively quantify where it's going, but I'm sure with, more precision quantitative approach, you're able to, depict the flows. So that's sort of what diagnostically, what it's being used. But I want to introduce you about microbubbles also, which gives insights into the brain, functional insights into the brain using ultrasound. So I'm not sure if you're all familiar with microbubbles. Show of hands if you've heard of microbubbles. Okay. So the majority have not heard of microbubbles, which is good. So this video will be helpful. So these are tiny microbubbles, gas-filled bubbles. They are commercially available and they're FDA approved for use as ultrasound contrast agents. And they reflect strong sound waves, okay? And they are 2 to 3 microns smaller than red blood cells. They come in an aqueous solution. You can inject it peripherally. And they come in a kit. It's very easy to reconstitute. And these are tiny microbubbles going through the circulation, and they distribute everywhere. The gas is biologically inert, and the gas is exhaled while the shell is just cleared up by the macrophages in the liver. And if you inject an image, you can get images of these tiny bubbles creating high echoes, okay, because of the reflection of the gas. And you can resolve very, very small microvessels if you are able to track these bubbles using analysis. This is actually half of the brain in a pig. And I'm going to show you some of the experiments that we did, but on the left is a microvascular track, and on the right is the microvascular velocity. And you can really track it down to less than 10 microns if using some sophisticated data analysis. So as I said, these microbubbles, when you're able to see them and resolve their point spread function and exactly follow their trajectory, then you're able to see quite nicely sophisticated flows in the human aorta and in the heart. And also, this is an image of microbubble tracks in the pig retina. It's one of the active grants that we have. This is our recent work on cerebral microvascular imaging using microbubble injection and tracking. On the top are, as I said, half of the brain of the pig. And at the bottom, we're trying to resolve microvessels at high resolution. Now I'll tell you why are we trying to resolve these vessels, and that's part of my work is to find physiologic relevance to doing all these sophisticated analysis. This is a hydrocephalus pig. So what we did was we put in a saline into the ventricles and we insufflated until their pressure increased. We elevated from baseline to about 50, 60. And so what you're seeing is a coronal slice of the brain of a pig at baseline and at very high ICP when the microbubble was injected. And this is a bolus injection, so you're going to see a wash in and wash out of bubbles, okay? On the left is baseline. On the right is high ICP. Now it's pretty clear just by visual. It is very clear. Now on grayscale, it would be hard to tell, honestly, because the ventricles are not that dilated. It's mildly dilated, but it's not that dilated. On the left, you're seeing prompt wash in and wash out of microbubbles. On the right, you're barely seeing any microbubbles because there's too much pressure. And so this is kind of what we're talking about in terms of the power of functional ultrasound. And when we actually track this over time, this is half of the brain. On the top is microbubble track. So this is baseline right here. And progressively, as you go to the right, there are elevated pressures. So at high pressure, you can see that the number of microbubble tracks decrease. And on the bottom are velocity. And the darker you are, the less velocity, decreased velocity you are. So you can see progressive decrease in velocity over time. And when you quantify it, and on the y-axis is CMC is just average microvascular velocity in a given region. And we normalize by pulse pressure, some sort of hemodynamic parameter. And you map it against ICP on the x-axis, and you can see a very tight correlation here. And this is just a derivative of the other graph. Pretty amazing because we don't have any tools to measure ICP non-invasively. So it's worth exploring this technology. Now we try to go through the eye because obviously there is skull, not that the skull prevents it, but that's actually one of the works that we're doing is to do super resolution through the temporal bone because that's the thinnest bone in the brain. And you are actually able to see contrast signal. But here we explored eye imaging because we all know that optic nerve diameter, and we use that all the time to derive ICP levels. So we wanted to see if we can track these ocular microvessels and if that has any relevance to ICP levels. And what you're seeing is the multiple sequential images of the eye at different slices. So we used a robotic arm to slide through the eye in order to minimize motion and variability. We imaged 6 parallel planes that are moved sequentially, and you can see the tracks on the top and you can see the velocity on the bottom if you mag it up. And I've only magged up the retinal images for you to see. You can see that at the top is the baseline retina microvessels. And as you go to the bottom, it's high ICP. And it's pretty interesting how the microvessels change. And I know that there are promising technologies in the ophthalmology world, and we're certainly collaborating with the ophthalmology colleagues to integrate not just microbubbles, but also other tools like OCT to test which ones or in combination would give the most precision prediction or assessment of ICP. As you can see that the morphology changes and also the microvascular velocity also correlates with ICP pretty strongly, which is fairly promising. So everyone has heard of diagnostic utility, right? And I think that's very promising, but keep in mind that microbubbles are also therapeutic tools. How do we make it a therapeutic tool? I'll show you. So the same microbubble, instead of putting biologically inert gas, can have other gas, such as xenon or argon or whatever neuroprotective gas we want to put. And of course, we can also put drugs in the shell or outside the shell, load it up, and same delivery mechanism. So you would inject peripherally, and it would distribute everywhere. The point here is that you are able to control its behavior with ultrasound, and that's key. When we talk about nano platforms, it is hard to control its release. It goes everywhere, and sometimes, it gets taken up. But with microbubbles, it circulates through the bloodstream, and it can pop when the ultrasound trigger is present. So this shows that, when you apply ultrasound, you pop it, you can release the drug. And there's one additional information that I want to tell you is that ultrasound alone with microbubbles can open blood-brain barrier. That's another research application. So how does it do that? When you, put ultrasound beam, microbubbles oscillate. And that creates shear waves and mechanical effects that open the blood-brain barrier. And so that's one of the things that we're doing in the lab as well, where you can transiently open the blood-brain barrier and deliver drugs. So there are two mechanisms here, which is you have microbubbles loaded up, you pop it at the carotid, then it can release it to the brain. Or if you have a drug and you want it to penetrate through the blood-brain barrier because it's not penetrable, then you can also load it up, also open the blood-brain barrier and have it cross. So that's, kind of in the beginning phase of research where actually the focused ultrasound and blood-brain barrier opening is not new. It's been around, but loading up into microbubbles and treating different diseases is fairly new, but it's promising. So what we did is, as I've shown that it can load anything you want, and with ultrasound you can release it. What we've done is we put neuroprotective gas, specifically xenon, into the microbubbles, and the pigs underwent traumatic brain injury. So they had a focal contusion, and this is published in Journal of Neurotrauma, where we injected xenon-loaded microbubbles into these pigs at different time points before 24 hours or after injury and within 24 hours. And we were able to see statistically different, significant difference in pericontusional edema after TBI as compared to controls. When we did histology of these pigs, the perivascular inflammation was less, and vascular integrity was more intact in these animals. Why xenon? It's something to explore. It is actually an NMDA receptor antagonist, glycine competitive antagonist. But we've done some cell cultures, and it has interestingly, it does protect the blood-brain barrier or the integrity with upregulation of tight junctions after glutamate and other insults. So more to come, but it's very intriguing. We've tested with endothelial cells, and that's part of that journal article. So in summary, there is a promising future ahead with advanced neurosonography, and ultrasound and microbubbles in combination are valuable tools and they're theranostic tool to tackle pediatric diseases. And I'd like to acknowledge funding sources as well as my collaborators. We have a big group of collaborators. It's not something that I can do by myself. On the top, Todd Kilbach, who I collaborate with in critical care. In the middle is Dr. Katz, professor of mechanical engineering at Hopkins, who I've collaborated since 2016. And Angela Vian is a pathologist, and in the middle are, my lab members as well as the bottom. And I thank all of them for being able to do this exciting work. Thank you very much. I wanted to leave room for questions.